Okay, welcome to our RadPath channel. This is something new, calling it RadPath Crash Course, How to Read a Pelvic MRI. My name's Matthew Hartman, and I'm joined by Katie Blankemeyer. We're coming to you from Pittsburgh, PA. Katie did a women's imaging rotation with us and did a fantastic job. And she made the comment that a lot of students, a lot of attendings in GYN don't know how to read a pelvic MRI, but would like to learn. So Katie did a great RadPath case. You can see it right there. And we are going to use that as an example for how to get comfortable reading a pelvic MRI. Again, all this material can be found on the ACR building blocks site and the special section med student curriculum building blocks. And Katie made use of the OBGYN senior module and the pelvic anatomy imaging overview, which she highly recommends. Again, we created an Anki deck for RadPath flashcards. There's a lot of GYN on there. Go to the About section on the YouTube channel to get instructions on how to download that. And again, we have other RadPath lectures on this channel, and we will be making our uterine RadPath lecture very shortly, which will complement this as well. So what we want to cover in this video: how to tell CT from MRI, some basics on pelvic MRI, T1 versus T2 versus T1 with contrast, and what is fat sat. So if we accomplish that, that is pretty awesome. Then we're going to review how to distinguish solid from cystic on MRI, CT, and ultrasound. And then a simple approach on how to identify some pathologies using a RadPath case.
All right, so this is Katie here, and I'm going to just, to start off, just go over a brief overview of the basic anatomy of the uterus, just as a reminder. So here we can see our major female pelvic organs. We have the uterus, which is basically made up of the fundus, which is the top of the uterus, the body of the uterus, which contains the endometrial cavity, and then we have the cervix, and below that, the vaginal canal. On either side of the uterus, we have our adnexal structures, which are included in the fallopian tubes and the ovaries. And just a little bit about what these structures normally look like on imaging. It's important to note that the uterus can vary considerably in its size and appearance based on whether or not the patient is premenopausal or postmenopausal, whether the patient is pregnant, whether they were recently pregnant, lots of different factors. But more or less, the uterus generally has this inverted pear shape. It's located behind the bladder and anterior to the rectum. And for a long time, ultrasound has been the modality of choice for initially evaluating any type of uterine pathologies. When you're looking at it on ultrasound, usually the echo texture should generally be homogeneous. And if you still aren't sure what's going on, a lot of times you can get further characterization of the pathology with a CT or an MRI. And just an important thing to note is that you have to remember the physical exam findings as well. The uterus sometimes can be palpable when it's enlarged on pelvic exam, and that can kind of give you a hint to what might be going on. All right, so when I started this course, one of the biggest things that I wanted to learn is, how do I know if I'm looking at a CT or an MRI? If I don't have any labels and I just have an image thrown up in front of me, what are some clues that I can use to figure out what exactly I'm looking at? So looking at these three images, these are three sagittal views of the female pelvis, and some clues that I'm looking at to figure out if I'm looking at CT or MR. So the first thing I'm going to do is I'm going to look at the bones. And I can see on the left picture, the bones are bright white. And on the middle and the picture on the right, the bones are kind of darker. So right there, that kind of tells me that the picture on the left is a CT, because the bones are always going to be the brightest thing on a CT image. And on an MRI image, like the one on the right, the bones are always going to be dark. Another thing that you can use as a tip is on a T2 MRI, the bladder is going to look bright because fluid, so like cerebral spinal fluid or the bladder, is always going to show up bright white on a T2 MRI. So based on those kind of tricks, I know based on looking at these three images that on the left we have a CT scan, and on the middle and on the right we have an MR. And I can go and see if I'm right now by looking at the labeled images. And yep, we are right. On the left we have a sagittal CT. In the middle, we have an MR actually showing a 24-week gestation. And on the right, we have a sagittal T2 of MRI of a normal uterus. And they actually also point out on here that you can see the endometrial stripe in that right picture, which shows up as a hyperintensity.
So our next learning topic is solid or cystic. And again, this is from our basic rad path lecture. This is one of the most important things that when I get students to try to convey to them, to have them learn over the course of the month, what does water look like on the different modalities? So this is a renal cyst from the left kidney. And we're going to use the correct terminology and describe this as anechoic, completely black. And we're going to switch to CT now, talking about Hounsfield units. Again, this is CT. The bones are the brightest thing on the image, like Katie was talking about. We get this dark lesion, left kidney. We use something called Hounsfield units. We get 2, very close to 0. This is water. So water is 0 Hounsfield units on CT. And finally, we move to MRI. As Katie said, the bones will be relatively hypointense on MRI. And then we try to decide T1 or T2. The CSF is hyperintense. So this is T2, again, T2H2O. And then we have our renal cyst, which is T2 hyperintense. So we will be focusing on MRI basics right now. T1 versus T2, and then T1 with contrast. And we're going to use Katie's rad path case to show these different sequences. Okay, this is Katie's rad path case that I'll be going through the imaging for. This was a 59-year-old female who had a history of pelvic pain. Also had a history of pancreatitis, which we'll be showing those images too on the CT. But I just wanted to show the ultrasound first, which we always say is the first modality anytime there's any pelvic symptoms, pain, abnormal bleeding. This is the modality to start with. And I agree with that. But in this case, I'm going to say it's hard to make heads or tails of what's going on here. This is the uterus, and I think everyone will agree, very heterogeneous, probably a lot of fibroids. I'm not seeing the endometrial stripe. Depending on what you're worried about, you need more information. So I just wanted to show the ultrasound first. And then we're going to move to the CT real quick. Like I said, she had pancreatitis. This is a nice example of peripancreatic inflammatory changes going to the retroperitoneal spaces there into the right anterior perirenal space. But what we care about is the pelvis on this case. And we're going to see a couple of masses and trying to figure out where this is coming from. I like the sagittal as well. Again, this is a CT. Our bones are bright. Here's soft tissue windows. That's when I'm doing these buttons, I'm just changing where our gray scale is. Here's our bladder. Here's our actually, that's not the bladder. Our bladder is right here. This is actually a fake out. A lot of people would think that's the bladder. But our bladder is very small right there. We'll see this on the MRI as well. But this is a mass. And our vagina sort of stretched behind it. And it's unclear, is this coming from the cervix, the vagina? Is this the ovary? We're not sure. And again, not seeing the endometrial stripe very well. So let's move to the MRI. That's what we came here for. Anytime I read a pelvic MRI, I always start with the sagittal T2. But let's review first. How do we know this is the MRI? Well, the bones are relatively dark compared to our CT, right? So that's our first step. This is MRI, and then T1 or T2. Look at the CSF. It's T2 hyperintense. We have a T2 image. And here's our bladder again. The bladder contains, urine or water. That should be T2 bright also. And again, we can see it real well here. and much different from this mass, which is right in front of the vagina cervical region. And then we actually see the endometrial stripe here. T2 bright, nice and thin for a postmenopausal female, but we see a big submucosal fibroid right behind it. And this lesion, which we're going to try to figure out, is this coming from the uterus or is this ovarian? But we can say it is T2 hypointense. So this is going to be solid. So remember, things that are cystic are T2 hyperintense or bright. This is the opposite. This is going to be a solid mass, and we'll see this on T1 as well. Something I wanted to talk about is fat saturation, which is something we'll see on T1 images. So these are our axial images, and I got them linked, and we will see that our CSF is going to be dark. So this is a T1 image. These are axial images. Our bladder is also dark, so T1, but this is also going to be T1, and you're trying to, I'll give you guys a couple seconds to say, what's the difference between here and here? And I'll say, let's focus on the subcutaneous fat. This patient got an instant liposuction. This is what we call fat saturation. All the macroscopic fat has been nullified. It's going to be dark. If only life were that easy to get a liposuction. This is going to be very helpful when we have fatty lesions such as teratomas. They will be bright on the regular T1. You give them the instant liposuction with the T2 with the fat sat, which can either be on T1 or T2, and it will go from bright to hypointense. You have just diagnosed macroscopic fat, and that's one way we diagnose dermoids. So we'll have that in another lecture. But that's our T1. And then for a special treat, we have another T1 image here. This is also fat sat, but can anyone see what's the difference with this image? The vessels are going to be brighter. Got some periuterine vessels, our iliacs are lighting up. This is after gadolinium administration. This is a T1 post-contrast. And we are going to see that our lesion is enhancing. We expect that. Solid masses usually enhance. And you can see, let's show it on the sagittal. And the great thing with MRI is getting all of these multiplanar images. I think this shows it really well. Again, here's our bladder, a little bit of gadolinium going in there. That's the bright spot there. But we have this part at the level of the cervix, which is enhancing not the same, almost the same degree as the uterus. We have that fibroid up there, which is enhancing similarly to the rest of the uterus. So these are going to be moldable solid masses in the uterus, moldable fibroids, and this one looks like it's coming off the level of the cervix. And we will see if we're right with Katie's gross specimen, which she was able to follow this patient from the imaging to the OR to final pathology.
Alrighty, so after this patient had all of her imaging, she was taken to the OR and she had a total hysterectomy, and this is the growth specimen that we got. So on the left, you can see this is the normal uterus at the top with a few small fibroids on it. And then this is that big mass that we were seeing on imaging at the level of the cervix. And when we removed this, it really was a very, very solid mass. It was completely taking over the area where the cervix should be. You can actually see labeled here, this is where the actual cervical os would have been on a normal patient. So this large mass was really just taking over the anterior cervix. And then once we dissected the mass, you can see it was very, very solid on the inside. It was kind of this tannish, whitish tissue that kind of had this world appearance to it, which is very consistent with what a fibroid normally looks like. So then the pathologist was able to take samples of this and look at it more closely. And we have our histology as well, which I will bring up now. Okay, so here we have our histology images of that mass that we saw on the previous slides. So here we can see this is kind of a zoomed out, only a 40 times amplification image that shows at the top, we have the mass, which was diagnosed to be a leiomyoma or a fibroid. And at the bottom, we can see what normal myometrium would look like. So let's zoom in a little more. This is 100 amplification, and we can see the cells are kind of these oval-shaped spindle cells, kind of making this kind of swirled appearance, also consistent with a fibroid. Here we can show these pink areas show just some hyalinization, which is normal in a fibroid. And then this is interesting. You can see that these empty spaces here, the pathologist said this may represent fat cells, which is consistent with the final pathology, which said that some of the mass was actually a lipoleiomyoma, which is basically just a subtype of fibroid that contains fatty tissue as well. And then here, this is our most zoomed in image. You can really see here that these spindle cells are nice and oval shaped. There's no mitotic figures, no atypia. So this is really reassuring to us that this is just a fibroid and not anything more serious like a sarcoma. Alrighty, so that is all we have for you today. Thank you so much for listening. We really hope you enjoyed this lecture. And if you are interested, we should have more lectures coming in the future on different pathologies like dermoid tumors, as well as ovarian cystic lesions.